The following podcast is part of a certified educational activity titled Tackling Obesity in Psoriatic Arthritis, Key to Better Outcomes and Overall Health. Access the entire activity and complete the post-test at peerview.com/CKQ860. Downloadable slides and practice aids are also available.
Hi, everyone. Welcome to Tackling Obesity and Psoriatic Arthritis, Key to Better Outcomes and Overall Health. I am Alexis Ogdi, and I'm going to be doing this panel with Bob Eckel and Elaine Husney. Our goals today are to augment your knowledge of therapeutic implications of obesity and psoriatic arthritis. I think this is a common topic these days. What are the benefits of weight reduction and how do we do that? We want to equip you with strategies to identify candidates for weight loss pharmacotherapy and give you kind of some guidance about how to utilize weight management strategies, including pharmacotherapy. And how do we include this within our psoriatic disease care plans? Now, I think many of you joining us know the importance of comorbidities in patients with psoriatic arthritis. Cardiovascular
Mhm.
comorbidities and cardiometabolic disease is really common in our patients, much more common than in the general population. Sometimes we're the ones to pick up the hypertension, and we often pick up the dyslipidemia, and we often see the diabetes first just because we're checking the labs. We know that obesity is very common in our patients. In the US, almost half of our patients with psoriatic disease are obese. Type 2 diabetes affects about 20%, metabolic syndrome somewhere around 20 to 30%, dyslipidemia up to 64%, and hypertension somewhere in that 30% to 40% range as well. Not only that, but also depression is very common in our diseases, depression and anxiety. Those can kind of be paired with obesity sometimes too. So, this is one of the reasons that we want to tackle obesity. And we're going to talk more about why obesity is so much more important in psoriatic disease and its implications for treatment response. All right, so we're going to start with a motivating case to kind of help us dive into this topic tonight. Lisa is a 46-year-old woman. She has a history of psoriasis diagnosed about 12 years ago, psoriatic arthritis diagnosed just in the last year, as well as a new diagnosis of hypertension about a year ago. In addition, her family history includes heart disease in her father, as well as diabetes, and her mom had psoriasis and a stroke about 4 years ago. Her current weight is 227 pounds. Her weight circumference is 104 centimeters, and BMI is 35.5. Her blood pressure today is 142 over 88. Current medications include adalimumab, a topical for her psoriasis, and losartan for her blood pressure. Today, when she comes in, by the way, as a side note, she's married with two children and an elementary school teacher. So today she comes in because her psoriatic arthritis symptoms have been worse a little bit lately. She continues on adalimumab, but is wondering about other options for therapy and what her next steps may be. She's been having some hand and wrist pain and having some difficulty writing on the chalkboard and maneuvering the laptop keyboard in class. She's also upset about her weight gain over the last 10 years or so. And given her family history of cardiovascular disease, she's a little bit worried about that too. She's also seen the posters in your office about the increased risk for cardiovascular disease and psoriasis. So she wonders more about that today.
Thanks, Alexis. I think, as you know, this is really typical for the type of patients that we see, especially sort of that lag period between being diagnosed with psoriasis and then developing psoriatic arthritis symptoms. One of the things I struggle with, I think, as we are really pressed for time sometimes during visits, is when you have so many things you want to address, right? So, as a rheumatologist, I always want to know who is on their care team. Are they close? Are they working with their primary care? Do they have a cardiologist? I think all these are sort of important to set the stage because sometimes it's difficult to have time to address everything that's going on. So I think addressing who is in their sort of care team can be really helpful in how we are going to be working with that patient.
Yeah, I mean, the weight is an issue here. And I know that you've described that patients with excess body weight have a lot of issues that also are comorbidities of excess body weight that can impact the natural history of psoriatic arthritis. So this becomes an issue for you in the clinic. And in rheumatology clinic, just like in cardiology clinic or gastroenterology clinic, there's not a lot of time to address obesity as an issue. And I think that's one reason we're having a seminar this evening is to see ways in which we can address the obesity problem, even in subspecialty clinics like rheumatology, to get an outcome that's more favorable.
Perfect. So I'll turn it over to you, Bob, to tell us a little bit more about obesity and how you think about this as an endocrinologist and cardiovascular disease.
Well, the issue of obesity etiology is a very complex interaction of a wide variety of factors. Some of these the patient has some control over, many of them they don't. Neurobiological factors are complex and relate to the central nervous system in terms of how it regulates body fat. And I should just mention, we all gain some weight as we get into our adult years, and we usually stabilize at a certain weight. But losing weight is just like controlling your weight when it was thinner. Ultimately, your brain knows what your body fat content is. And so losing weight's hard. And therefore neurobiological factors really relate to a large extent of maintenance of the obese state. We know genetics play a role here. The whole issue of patient control relates to energy intake and energy expenditure in the way of physical activity. But socioeconomic status is often out of our control, as are some of the many psychological issues that people with obesity face. So here's the complex etiology and maintenance of the excess body fat that's a challenge for all of us, both patients and healthcare providers. Now, when we look at ultimately the next slide, which in fact addresses the definition of obesity, historically, the BMI has been what's been utilized. But we've gone beyond BMI now, and the ACE guidelines in 2016 identified excess body fat as a definition of obesity. Now, excess body fat can be measured by a wide variety of manners, including waist circumference for body fat distribution, waist height ratios, and as I'll mention on the next slide, as part of the Lancet Commission on Obesity, even using DEXA occasionally to look at body composition. Now, the BMI is still to be utilized, and for non Asians versus Asians, there's a bit of difference when we get into a healthy weight, being overweight, or the definition of class 1 obesity. And that's because Asian populations tend to distribute their excess body fat more intra-abdominally. And we know that the intra-abdominal distribution of excess body fat relates to a lot of the metabolic complications of excess body weight. So when we're looking at comorbidity risk, we're looking at a gradation from underweight, which is not a risk factor because of excess body weight, but there are other problems that relate to being underweight. And then with increases in body weight in terms of comorbidities, we're looking at a range from overweight to class 3 obesity, where in fact comorbidity risk increases in a gradient manner. We have waist circumferences here that relate to risk for type 2 diabetes, hypertension, and cardiovascular disease. And here are definitions that relate again to a gradient of definitions from overweight to class 3 obesity, which all relate to ultimately some of the complications that have been mentioned that you see in patients with psoriatic arthritis.
We see waist circumference. And so in rheumatology, we don't think about that very much. And I think as we were talking through this content, Elaine and I were saying, well, we don't really, I mean, we know that for studies, but do you recommend doing that in clinic or how do you use waist circumference?
Yes, I think the waist circumference is a critically important measure because, again, the distribution of body fat has a lot to do with the comorbidities we associate with obesity. So, and that needs to be done carefully, and guidelines for almost all organizations that deal with obesity define how to do it accurate and reproducible and validated waist circumference.
Thank you.
Now, we won't take time now to go through those measurements, but I think you can look at guidelines to show you how to do one accurately and one that's validated. Now, I was part of the Lancet Commission for a diagnostic model that differentiates preclinical from clinical obesity. Don't dismiss BMI, it has relevance, but everyone with a overweight BMI is not associated with excess body fat. And there are people whose BMIs are normal that have an excess amount of adipose tissue. So we want to confirm excess adiposity by a waist hip ratio, ultimately a waist circumference as body fat distribution is important, as we just discussed, or weight height ratio, which the bridge like a lot in the NICE guidelines for assessing obesity. Now, based on an assessment of excess body fat, there are people who don't have excess body fat whose BMI may be elevated. And the athlete's a good example. Mike Tyson is a famous boxer whose BMI is 32 and a half. I mean, he's not overweight. His body fat content is 5% of his total body weight. So here's an example, an extreme one of an athlete who has a high level of BMI who does not have excessive body fat. But obesity is defined as excess body fat. Now, when obesity is associated with an obesity related organ dysfunction, major limitations of daily activities, or both, we're defining that patient as having clinical obesity where a therapeutic intervention relates to the need to lose weight. Now, what about someone who has excess body fat who does not have any of these criteria for clinical obesity? What do we do here? Well, we need to assess their risk for progression to a disease that we associate with clinical obesity. And a good example here is type 2 diabetes. Ultimately, a patient has a diagnosis of prediabetes that their hemoglobin A1C is 5.7 versus one who's a 6.4. We're much more concerned about the one who has excess body fat and has an A1C of 6.4. So that patient would need to lose weight. But maybe not everyone who falls into the preclinical obesity needs to lose weight, but many do. And for individuals there, we would caution them about gaining more weight. So here's a current paradigm of approaching the diagnosis of obesity that relates to going beyond BMI, defining these patients as having excess body fat and having preclinical versus clinical obesity.
Thank you for that nice overview of obesity. Now, I'd like to maybe turn our attention a little bit about how that relates to somebody with psoriasis and psoriatic arthritis. So, here we have this nice sort of cartoon picture that really highlights the multiple paths and the multiple cytokines and pro inflammatory cytokines that we see in this disease. And there is not only just a one way, but a bi-directional relationship of these cytokines with each other. So they're produced in excess in the adipose tissue. So, as we know, visceral fat is not just a static uh, visceral fat that sits there, but there's actually an increase in excess of cytokines that can be produced when you have extra adipose tissue. And then conversely, when you look at the skin side of things, an inflamed skin and active synovial tissue, active synovitis that we see as rheumatologists can also produce a lot of these pro inflammatory cytokines that can then exacerbate all of the obesity related comorbidities. So, in particular, why I was so excited to be part of this program is that we're really going to take a deeper dive into not only how to define and diagnose obesity in the general population, but how does that relate in patients with psoriasis and psoriatic arthritis, and what we really need to be careful of in this particular patient population.
The adipose tissue also has so-called M2 macrophages. As a non-immunologist, I'm criticized for using M1 and M2. But all that aside, these M2 macrophages are phagocytic, and they play a very important physiological role of taking up lipid and cell debris from fat cells that are turning over in adipose tissue. So everything in adipose tissue is not pro-inflammatory. They're macrophages that do good to adipose tissue physiology and biology. I'll just make that quick point.
Thank you. So now we want to sort of take a look at the connection between obesity and psoriatic arthritis. What do we know in the literature that obesity is associated with psoriatic arthritis? So we have studies, and you have a whole list over here in the dark blue where we have increased incidence, increased likelihood of transitioning from psoriasis to psoriatic arthritis, and then importantly, your disease activity and your disease severity can also be affected by patients that are obese. We also know that you have increased pain. You can have a decreased response to treatment, which I'd like to talk a little bit more in the next couple slides. But also sometimes a need to switch therapy due to obesity adverse events. So having them just side by side alone also affects how we think about the disease process, and then the different increased comorbidities that we'll also go into. And we also know, conversely, when a patient with psoriatic arthritis has weight loss, that there are benefits that come with this. And so we can see reduced incidence, reduced likelihood of that transition, and that reduced severity of disease if they do have a more normal weight. So I think this is really interesting to both look at the obesity associated with psoriatic arthritis and to tell our patients that there are huge benefits that if you have a more normal weight, that your disease process will also be easier to treat and easier to deal with. So, the other thing I would want to really emphasize is that when we're evaluating risk factors and looking at signs and symptoms of psoriatic arthritis, that it's important to also remember that there's certain risk factors that Alexis and I are really familiar with in a patient with psoriasis that may have more psoriatic arthritis. So you could see this list: nail involvement, if you have more body surface area affected by the skin disease, elevated BMI, and then having certain symptoms such as heel pain or enthesitis or fatigue. And then in your history and physical, it's important to note that if you have a family history, we also look at psoriasis and what we call hidden sites. So it's important. Not everyone's going to present with, classic psoriasis, plaque psoriasis that's, covering over 10% of their body. You might have to look at hidden areas. So behind the ears and the scalp, areas that can be covered by hair. And then we also want to screen for related conditions such as inflammatory bowel disease, and uveitis. So, all of these are also important to take note in patients with psoriatic arthritis, that they can have both risk factors and really hidden clues in physical exam that can tell us that this patient has psoriatic diseases. So here we also want to look at comprehensive assessment. So what do we mean by that? So we all know that it affects the skin and joints, and you can have disease activity and functional and patient-reported outcomes. But we do also look at overall disease severity. So in addition to the joint counts that we do a lot and looking whether there's axial involvement, we also look for enthesitis and dactylitis. So these are sometimes a little harder to pick up. And then in terms of skin disease, we want to know about the body surface area. And we also want to know about high impact sites. So sites that might really not affect you by so much percentage wise, but in areas that really mean a lot to a patient. It might bother them at work if they have a lot of enthesitis, for example, or maybe high impact sites that are very difficult to take care of, such as the nails and the scalp. We also have a measurement called Rapid 3 that we use, originally used a lot more commonly in rheumatoid arthritis, but we know that they can also be very helpful in patients with psoriatic arthritis, where we get sort of a composite looking at physical function, pain, as well as patient global assessment. And then PSAD, which is a newer patient reported outcomes made specifically for psoriatic arthritis, also looks at how the physical impact on pain function and your work capacity, as well as the dermatologic fatigue and psychosocial impacts that you have. So we have the PSED 12 also, that's very specific for psoriatic arthritis patients. And here I just want to show some slides, some pictorial slides, just so that we can understand that wide spectrum of patients with psoriatic disease. So here you can see pictures that affect more sort of classic skin plaque psoriasis, and then we have nail involvement. And then the bottom slides, you can see this dactylitis and enthesitis, which I think are a little trickier sometimes to pick up on physical exam, but very important because dactylitis, really many of the only things that we see, Alexis and I see in dactylitis, is going to be people with spondyloarthropathies or specifically people with psoriatic arthritis. And then lastly, the enthesitis, which you can see here, large Achilles tendonitis.
It's my task now to work with you to define weight loss needed to improve disease outcomes. This is really an important consideration for all clinicians who are dealing with excess body fat. So, to prevent type 2 diabetes, ultimately, it doesn't take much more than 5% weight reduction. And that's a series of studies that are international. The most famous of these are the Diabetes Prevention Program, which 5 to 10% weight reduction was all you needed to reduce glucose tolerance to the point of not developing type 2 diabetes if you had prediabetes. But here, anywhere from 5, sometimes up to 15 or 20% of weight reductions needed to lower glycemia. And that relates to maybe endogenous insulin secretory capabilities, may relate to the degree of insulin resistance, which is a major factor in type 2 diabetes, et cetera. So the variability there in terms of glycemic improvement is there for type 2 diabetes glycemic improvement. The CVD risk reduction ranges anywhere from 10 to up to 35% in terms of the clinical trials. And of course, CVD risk reduction deals with not only atherosclerotic cardiovascular disease, but deals with heart failure, cardiac arrhythmias, and beyond. Hypertension, again, it relates to the duration of hypertension, the presence or absence of hypertension that's due to resistance to hypertensive treatment, et cetera. So I think, again, that variability relates to the duration and the number of patient medications that are necessary to control blood pressure. Sleep apnea now has a FDA approval for tirzepatide, and sleep apnea probably requires a little bit less weight reduction, either from lifestyle or from pharmacological intervention. Type 2 diabetes remission is a controversial topic. How do we define type 2 diabetes remission? But anyway, I think the surgeons like this definition of finding out that bariatric surgery, probably even better than pharmacotherapy, can modify the natural history of type 2 diabetes to remit the disease, at least for a period of time. Fatty liver disease, called MASLD, really is highly variable, and ultimately that may require a little bit of risk reduction or may require a lot more, depending on the extent of the fatty liver disease that's present. Kidney disease, probably not too much weight reduction to modify the natural history of the fall in EGFR over time and a reduction in proteinuria. And osteoarthritis and PSA, I'm going to leave up to the rheumatologist, but the range there ranges from 5 up to 20%.
I do want to comment on that because I think we'll come back to this as we talk more about weight loss and the impact on disease. But you can see how much less, it doesn't take that much there. So,
Well, this is good. Okay, back to Lisa now. The medical history's been reviewed by Alexis previously, and under the plan, there's going to be some need for psoriatic arthritis, additional workup, and consider therapeutic adjustments and the weight reduction. Now she comes to me, or maybe even to you now, to think about things to consider with this patient. She's well aware of the metabolic and cardiovascular disease comorbidities associated with psoriatic arthritis and her excess body weight. And she'd again like her therapy to be adjusted. But she's upset about her weight gain over the last 10 years, and she's worried others will be judgmental. By the way, obesity biases are very, very common in the clinic and in the public in general. And we've got to really be aware of that in every practice of medicine we do. The patient has some responsibilities, yes, but we need a very careful history with no biases projected as we take a good history and do a physical exam and make therapeutic recommendations in taking care of people living with obesity. And although for Lisa, bariatric surgery and pharmacotherapy can be discussed, she's decided she's going to buckle down now and using her family gym membership and rejoining a local weight loss group. Now, here are some things we can discuss here. What are the best practices for discussing obesity, its impact on psoriatic arthritic patients? What therapies would you discuss after TNF failure? I'm going to leave that up to the rheumatologist. And what are weight maintenance challenges after losing weight and biological features that play into weight regain? I'm going to let Elaine and Alexis drive the bus on these various questions that we're posing to our audience.
Yeah, I love the question about best practices around obesity. Like you said, Bob, I think the challenge is, finding that right time to discuss this. So, I mean, how often are we presented with patients and we know this is a topic, but sometimes, unless the patient's also ready to talk about it, I find that to be sometimes difficult to navigate. I would love to hear what are some of the baby steps that you take, when somebody does want to start talking about it?
Well, the question is, should the healthcare provider, him or herself, be inviting the patient to talk about it? I think bringing up excess body weight as a risk for progression of psoriatic arthritis is a very important topic for rheumatologists, if not for the primary care physicians or the dermatologists. So I think if the weight relates to the treatment paradigm to follow and recommendations that relate to advancing therapies, I think it needs to be brought up. We think that maybe your weight is contributing a little bit to your symptomatology. And have you thought about weight reduction? It's something very cautious like that that allows the patient to say whether they'd like to talk about it. And by the way, if they don't want to talk about it, you can even close that discussion by saying, well, we still think your weight's important, but now let's turn to other options we might have. But I think in my first visit to a patient in the clinic that has been living with obesity for decades, that's a 1 hour visit going into everything from birth weight to age of menarche to weight gain after pregnancy, on and on. This is a complicated history assessing various treatment successes that have been previously experienced versus the frustration they have to biases, et cetera. The rheumatologist doesn't have time for this. So you've got to decide what your limitations are in the way of your practice to know how far you should go down the road in assessing the histories and therapeutic challenges you have before you.
Yeah, my approach is generally similar to that, which is I go through, we do their history physical exam, and then we're starting to talk about, okay, things are not good right now. So what are
Yeah.
our options? And so one option is we change your therapies around, and so we'll come back to like which therapy we might select. But I will go through the different options. As a part of that, though, I say we have these kinds of therapies that treat your psoriatic arthritis. But in conjunction with that, we will often use additional methods to try to get you to feel better. And so those things may include weight loss, your BMI. So this is where BMI is helpful for me because it's greater than 30 or something like that. I can say your BMI is greater than 30. Our data is all based on BMI and rheumatology. And so we say that opens the door. It's an objective number. So we know that patients with a BMI of greater than 30 have half the likelihood of achieving minimal disease activity, and so that is an option that we know that weight loss actually improves outcomes. So that's another thing we can address. And then I go through the other thing we can address is depression and anxiety because we know that's associated with a reduced likelihood of response to therapy. So anyway, we kind of continue on down and then we wrap back to what they want to talk about and leaves that door open. I also write it in my plan as well. But you're right. Going to the weight management is ideal because you guys have the time to tackle it. On the other hand, it's really hard to get into weight management these days. Let's go into topic number 2. So this is weighing up medication options for obesity and PSA. Um, Lisa, again, she's coming back now. Her BMI is 34.5. Her which she's had 3% body loss of body weight after getting to the gym. Her weight's now her previous weight was 227. She's now down to 220. Blood pressure is a little bit better. And we had changed her medications around to ixekizumab, adalimumab to ixekizumab, just to change the class of the medication from a TNF to IL-17. We could have a whole discussion on that. In fact, Elaine and I do other topics where we talk just about those kinds of things. But she comes in today and she's frustrated that over the last 8 months, she's been working really hard on diet and exercise and just hasn't really gotten to the place that she wants. She's gotten 7 pounds down, which is awesome, but she's still in that, obese range. We discussed options with the potential. So she wants to discuss options with the potential for greater weight loss. How would you talk through this? And I'll let you take over, Bob.
Well, I think medications now are an option for her. Physical activity doesn't cause much weight reduction, but Clark, deficits do. But yet, the lifestyle, opportunity should be there for everybody. We want them to have a healthy lifestyle. But she didn't lose much weight. 3% is not enough. And ultimately, her arthritis is probably not modified favorably because of that. So, we're going to talk about pharmacological therapy and perhaps surgical approaches that may be necessary. And I think, that's gonna enter into a series of slides that I think are gonna follow. So we'll wait for those.
Okay, so this is treatment guidelines for obesity. Just as a note that actually all of our treatment guidelines for psoriatic arthritis, whether it be GRAPPA, EULAR, or ACR-MPF, suggest that obesity management and having a healthy weight are important. ACR-MPF goes so far as to say weight loss is recommended in patients who are overweight or obese. And so that is unique to psoriatic disease. None of our other Like rheumatoid arthritis guidelines don't necessarily say that. So shows you how big of a problem this is here. I already mentioned a couple times that weight loss is really important in psoriatic disease, and we showed that slide that 5 to 10% of body weight loss actually has an impact. Well, this is data from a study. Let's start with the left panel there. A study in which patients who were initiating a TNF inhibitor were randomized to one of two diets. All these patients were obese. They were randomized to either a hypocaloric diet or freely managed diet. And they found that patients who lost 5 to 10% of their body weight achieved were much more likely to achieve minimal disease activity with an odds ratio of 3.75. And if they lost greater than 10% of their body weight, the likelihood of achieving MDA compared to those who didn't lose up to 5% of their body weight was 6.67 times. So, really huge impact here. And it turns out it didn't really matter which diet you tried. The real critical outcome was how much weight loss you had. Now, if we slide over to the right panel, this is change in outcomes in a different study in which they had everybody on a low calorie diet. I'm sorry, this is still from the same study. There's another study that looks exactly the same though. So they had a drop in their ESR, their CRP, their tendon and swollen joint counts, etc. So weight loss really did help for these patients. This is the other study I was mentioning. So again, you see that in patients who were put on a low calorie diet, this is just a single arm study of 41 patients. Their DAPSA score, or disease activity in psoriatic arthritis, which is a combination of tender and swollen joint counts, patient global patient pain, and C-reactive protein, dropped over 6 months as they lost weight. And the DAS 28 CRP is shown here. That is actually not a psoriatic arthritis outcome measure, but they included it here nonetheless. And again, you see it drop. And then if we slide over, this shows the differences in outcomes from baseline. So there was a ACR 20 of 51%, ACR 50 of 34%, and ACR 70 of 70%. Those are the TNF inhibitor numbers. Those are our gold standard numbers for anything. And then you can see some other outcomes here, but achievement of MDA was more around the 54%, which is high. So this was really remarkable outcomes from weight loss alone.
All right. Well, we need to screen first, and screen begins with BMI, and then beyond that, assessing excess body fat by the measures we talked about previously. So this is the U.S. Preventive Services Task Force. It says all the adults should be screened for obesity, and those above 30 need to be referred for intensive multi-component behavioral intervention. And again, psoriatic arthritis is a lifelong condition, and keeping weight off is an important challenge and worthwhile in terms of the outcome to follow. So let's begin with lifestyle that relates to getting down to a healthier body weight that could be anywhere from 5 up to maybe a 30 or 40% weight reduction. And obviously, that helps more than psoriatic arthritis, but also helps many other comorbidities of obesity. We need to enhance obesity medication responses. We need to make sure people stay on the medication. One of the concerns, I think, is muscle loss seen with some of the pharmacotherapy. We'll discuss that briefly to follow. And then looking at general health in terms of quality of life measures and obesity associated psychological behavior. Anyway, here we're looking at a variety of medications we utilize, and many of them are somewhat historic now. Although naltrexone and bupropion do have actions that relate to dopamine, norepinephrine, and also relationship to some of the regulatory hormones that control appetite and food intake. And also phentermine topiramate also relate to dopamine and norepinephrine tone in the brain, and also the inhibition of the GABA circuitry and the cannabinoid 1 receptor. So all of these agents, phentermine, topiramate, naltrexone, bupropion, work directly in the brain, and they modify many peptides and hormones that relate to energy intake. Ultimately, the GLP-1 receptor agonist, beginning with exenatide, actually liraglutide and semaglutide shown here, and tirzepatide to follow, work mostly at the level of the central nervous system. So there are many neurons and many synapses upstairs that relate multiple neurons in a multi-neuronal system that relate to food intake. And that food intake relates to decreases in gastric emptying, early satiety, and that's the major mechanism by which these drugs work. They work through incretin-based biology, and the incretin system is part of our normal physiology, but they work in the brain to modify the sensing of these incretin pathways to modify food intake and satiety. Orlistat, which is rarely used anymore, is a GI lipase inhibitor which causes diarrhea, but also associated with some weight reduction. And there's many drugs in the pipeline, and I'll not review this classification of drugs in the pipeline to the left, but you're going to see many, many new compounds coming to surface, I'm sure, over the next 3 to 5 years. All right, so what can we expect? Well, lifestyle typically in the range of 3 to 10%. Physical activity alone doesn't do much unless you're a marathon athlete. If you exercise a tremendous amount, you're going to lose a lot more body weight. But ultimately, lifestyle is generally 3 to 10%. And most of the drugs that we've listed here are somewhere between 5 to 10% weight reduction. And by the way, sometimes when you subtract placebo, they may not even be that great. But now when we come to semaglutide and some comparative analyses with tirzepatide, a little bit more weight reduction with tirzepatide typically than semaglutide at maximum dose. So ultimately, these drugs both are very effective in causing a mean weight reduction in the range of 10 to 20% in 1 year. And then, of course, there's endoscopic and surgical interventions. So we'll not talk about the endoscopic procedures today. But bariatric or metabolic surgery relates to a little bit more weight reduction, 25 to 30%. And that's based on what surgeon you choose. You need to choose a surgeon if you're going to have surgery by someone who, in fact, has a history and approved for bariatric surgery intervention for maximum results. Okay, so when we think about the various drug classes, orlistat, we'll just mention briefly, it's mostly GI upset, which is troublesome for most people, and the amount of weight loss is not that great. And basically, we're not seeing much orlistat used anymore. And by the way, this whole issue of cholelithosis showed on the right as an adverse effect. That's true with any rapid weight loss paradigm, whether it's lifestyle, orlistat, naltrexone, bupropion, and beyond. The naltrexone, bupropion, constipation's not unusual, but anything that's reducing food intake and energy intake ultimately is associated with constipation. And with phentermine, I used a lot of phentermine in my day, and ultimately, constipation's very, very common with that, but sleep disturbances and occasionally, ultimately, cardiovascular disease, cardiac arrhythmias can occur. But phentermine, I think, tends to work in people who have an increased appetite. And if they're not eating because they're hungry, they typically don't respond to that. And now with the GLP-1 receptor agonists and GIP, GLP-1 receptor agonists, I think they're nausea, vomiting, constipation, diarrhea really are almost not adverse effects. They're expected. And therefore, titration of dosage from low dosage to higher dosage is increasingly important in these agents if we're going to prescribe them. Now, when we're thinking about the integrative mimetics, the GLP-1 RAs and the GIP RAs, in addition to GLP-1, in patients with psoriatic arthritis, we're thinking about a variety of mechanisms by which these drugs may be helpful. By the way, the amount of weight reduction may not relate to some of the cardiovascular disease outcomes. And in fact, the majority of these outcomes may not even be weight loss dependent. But of course, we're looking at the metabolic triads of lipids and glycemia that go beyond simply weight reduction. And ultimately, in terms of the rheumatology expectations, anti inflammatory effects, antioxidant effects, and endothelial dysfunction, which is modified favorably by the GLP-1 RAs and GLP-1 RA and GIP RAs that are available clinically. And we should keep all these plethora of effects in mind when we're going to prescribe these patients these kinds of drugs. And if we look at all the approvals, we'll go down list quickly for chronic weight reduction. Ultimately, most with one or more comorbidity, ultimately we're looking at most of these drugs as causing benefit. For glycemic control and type 2, all of them are approved for this indication. For longer duration and actually pediatric indications, we're looking at dulaglutide and liraglutide as approvals for that type of patient, even the younger patient. Cardiovascular disease, we see for liraglutide, semaglutide, and dulaglutide, with semaglutide oral being evaluated. And I know tirzepatide is being evaluated for that indication also. MACE with type 2 and multiple CV risk factors. By the way, these were people with established cardiovascular disease. And people with risk factors, dulaglutide is the only one at present. In terms of renal dysfunction, semaglutide weekly, subcutaneously, and that relates to EGR decline, end-stage kidney disease, and CVD death with patients with type 2 diabetes and chronic kidney disease. OSA indications only for tirzepatide. And for MASH, we see that only at this point for semaglutide. So here are all the FDA approvals with many to follow, I'm sure, in the next 6 to 12 months.
Let's continue on with the case. Lisa here, you could see her weight just kind of stable at 220. Her baseline was 227. Blood pressure was 132 over 78. Her current medications are, as you can see, we switched from adalimumab to izokizumab. Um, but now the question is, how do we start anti-obesity medication in a patient like Lisa? So, having just discussed a number of AOMs or anti-obesity medicine and bariatric surgery, Lisa is most interested in initiating therapy. Follow up in 1 month to monitor therapy, tolerability, and liver function tests. So it is so exciting for Bob to be presenting all these different options with all these different indications. And I have to say, patients are asking me directly, about these now. So now the challenge is, how do we actually start somebody on one of these agents? So in terms of navigating weight management, are there any known interactions or safety concerns when you combine this with our PSA treatment? That's probably one of our most common questions that we get. Given the known benefits, when should we actually, like in this case, Lisa, when do you think that lifestyle modification is done enough? Where then the next step is to start medication, and what criteria should rheumatologists use to identify the appropriate PSA patients? For actual anti-obesity meds.
All right, let's begin thinking about uh, how to go about treating patients with obesity. For the Action 10 study, which is noted here, this is a large international survey of perceptions, behaviors, and barriers for effective obesity care in terms of 14 plus thousand plus people with obesity that were surveyed, 2,700 healthcare professionals in 11 different countries and 5 continents. So here are the gaps that have been identified. Number one is delay in approach. I mean, it's amazing how many things in medicine have therapeutic inertia. That means we think about something, but it's 6 months later or here 6 years later for those with obesity to even discuss weight with their healthcare professional. There's something wrong here. But I think, the obesity pandemic as it exists globally now may change behavior of healthcare professionals and in addition, change behavior in our patients. The start of therapy, 68% of patients expected their healthcare providers to initiate weight discussion. Well, two-thirds were wrong. Their healthcare professionals did not initiate weight discussion. We talked about that a little bit earlier. And the healthcare providers themselves had low motivation to discuss obesity because they didn't feel like much of that discussion had any merit, that ultimately patients weren't that interested and weren't successful even if they tried to lose weight. Now, there's some strategies to improve obesity care. The 3D approach is first of all, discussion, secondly, making an adequate diagnosis, and third, directing the patient for effective therapy. So, bringing up the matter we've discussed, that's really critically important for all physicians in the healthcare space. Communicating the diagnosis of obesity as preclinical or clinical obesity and the need to lose weight or the need to prevent weight gain. And I think providing guidance and scheduling follow up appointments at a regular interval are incredibly important. And when you're unable to manage obesity in your own clinic, get it to somebody who can, who knows this area and can effectively describe the need to prescribe therapy and is comfortable prescribing all pharmacotherapy or advising for surgery when needed. All right, then we've got the 5 A's in terms of ask the permission to discuss weight, assessing the story that's been given to you and asking the right questions, by the way, before you assess the story, advising on management, the various strategies of lifestyle, the way to surgery, agreeing with your patient on goals, and finally, assisting with drivers and barriers that relate to the outcomes to follow. All right, now we're talking about GLP-1 RAs and GLP-1 and GIP RAs in terms of the approach to treating people with obesity. We need to remind patients, first of all, the potential benefits. Why are we treating their obesity? And here we got a whole list that we discussed: risk of heart attack and stroke and heart failure and CV related death and fatty liver disease and renal disease progression, reduced inflammation, which is critically important for patients with psoriatic arthritis or other rheumatologic disorders, by the way, weight loss and glycemic control for patients with diabetes or prediabetes. We need to discuss the potential adverse effects. And that's really critically important in terms of slow titration. And if you go very slowly and you get a lot of GI upset, usually nausea, but sometimes vomiting, back off on the dose and then gradually escalate more slowly. Encourage patients to communicate about their course in therapy and also their insurance coverage up front. Very important. These drugs are still pretty costly, so I think coverage is critically important, and review all the patient's medications in addition to the GLP-1 receptor agonist. So talk to them about hypoglycemia, and that's usually not important unless the patient's on sulfonylureas or insulin in addition to the GLP-1 receptor agonist. Advise them to eat slowly and smaller amounts of food. Instruct them to report side effects in terms of nausea, vomiting. Constipation's expected, so that one's a little expected to be common and not unusual in patients that are actively losing weight, and inform them again titration of dose and dropping back on the dose if they have symptoms. So, panel insights, best practices in team based collaboration. Many specialists may not view their role as a weight loss clinician, like maybe many rheumatologists don't, but are now often in that position because of the use and efficacy of these endocrine mimetics. What can you tell your rheumatology colleagues about these concerns? What tips would you provide your peers regarding collaborating with patients that treat obesity and a patient with psoriatic arthritis? And finally, what tips do you have for solo practitioners or small rheumatology practices who are now trying to manage obesity care? Elaine, Alexis, I'm going to turn some of those rheumatologic questions over to you, and we can return to obesity as a topic if and when we need to. Go ahead.
Yeah, I think it's important that we do view ourselves to be a weight loss person just because of the data that I showed you on how it affects your disease severity and treatment options. So we know that meds for psoriatic arthritis are going to work better if you have a more normal BMI. And so maybe we need to redefine what weight loss clinicians mean. So I think I have a role in educating and kind of telling our patients what we know about obesity and PSA. And then in addition to work with somebody like Bob who can actually, start the medication. So Alexis, I'm not sure how you think of this as well.
Yeah, I mean, pretty much very similarly. I think we want to get the patient to feel the best they can. And as rheumatologists, we're also internists. We did internal medicine training. We like
Yeah.
to think about the patient as a whole patient as opposed to just our issue. I mean, I think we're trained to do that. I think we're pushing people to do that more. I think the natural tendency is to focus on the joints. And even, Elaine and I talk about this all the time in psoriatic disease. You got to think about skin and the joints. Now we're throwing in more things. We also talk about comorbidities commonly. I think one of the nice things now is we have tools for this. We didn't have
Yeah.
tools for this before, and that really does change the game. As someone prescribing them, though, it's a huge headache to get them approved. So I think that is where our specialists are helpful, but we're having trouble with getting people into weight loss clinics. I'm not sure what
Oh,
your experience has been, Elaine.
Yeah, I think many people, see commercials and, they immediately think, okay, I have a medication. But as Bob knows that there are, ways to pick and choose which ones to use, which combinations, and when's the right time. And I don't think that these are going to preclude you from changing the lifestyle benefits as well.
well, keep in mind now when these drugs were approved, they were approved for the treatment of type 2 diabetes initially. That was their approval. And it took a while for the cardiologists to wake up that either this class of drugs or SGLT2 inhibitors had a major role to play in cardiovascular disease outcomes, both atherosclerotic cardiovascular disease and heart failure. And then the renal docs started waking up in terms of the natural history of renal disease. And now the liver docs are waking up about the role in fatty liver disease. I think, unfortunately, the kinds of trials that are being carried out in these other comorbidities are much more informative in terms of major reasons to use these drugs in these other diseases. You need to convince your fellow rheumatologists and your patients that this is as important to them in terms of the natural history of their disease as these other subspecialists have done.
Yeah. So speaking of solo practitioners, by the way, one of the other questions here, I know several of our solo practitioner colleagues are now doing weight loss management in their practice and just billing for it separately. So it's a separate visit. Many of them have either trained nurse practitioners or PAs or someone in the practice who can do that. So that's another option for it. And I think that is a at least bringing in value to both their patients and in terms of RVUs and funds. Okay, to close this out, any final thoughts, and then we'll kind of move over to question and answer. So let's start, Elaine, what would be one final takeaway you want to give to everyone?
I think just like anything else, you have to see how your practice is, and you should really go towards your strengths, right? Alexis, we had this problem with cardiovascular disease where we saw an increased risk, and we had to deal with, when to refer. So in obesity management, I think it's the same thing. You kind of go onto your strengths of what your own office could do, and then what we can refer out.
Exactly. Totally agree. Bob, what would be some of your key takeaways?
Obesity is important to rheumatologic disease, and I think discussions by rheumatologists need to take place. And ultimately, if it goes beyond their comfort zone, fine, refer. If in fact they get comfortable with GLP-1 receptor agonists and have the personnel to prescribe them with you, you need to get on board. I would encourage rheumatologists to get on board for something that helps their patients in terms of their disease and quality of life.
And I think I'll finish by saying my takeaway is it doesn't take a lot of weight loss. It's a lot if you're doing it all by yourself and trying to go to the gym and change food habits, especially for people in their 40s and beyond. But the 5 to 10% of your body weight can have a significant impact on the joints. So, as well as the skin. So that would be my key takeaway. All right. With that, I will open up for questions. What resources, including staff, have helped to facilitate comprehensive obesity management and coverage barriers in your practice? Oh, that's a great question. Either of you want to take that first? Um,
Elaine or me?
Sure,
Elaine?
sure. Yeah. Great question. So getting back to what I said before, I think you have to kind of know what your strengths are. If it's just education alone, I still think that's really important to educate the patient how important obesity is. If you can go to the next step, as Bob was saying, I think we're all on board. I think we just have our practices have to be kind of as nimble to see where we can do this. And if you can't, have someone to go through the prior auths, then I think it is really reasonable to work very closely with someone like Bob so that we can have a quicker referral for our patients.
To that point, in our rheumatology clinic, we have pharmacists, specialty pharmacists that
Yeah.
do the authors for our medicines. They didn't actually want to do the weight loss medicine one. But we have a weight loss specialty pharmacy group. And so they were able to tap into that group for help. So I think that was one other thing is knowing that there are these groups of specialty pharmacists within our health system that we didn't have to go all the way weight management clinic. We just need to go to the pharmacist. So that's just a little pearl for people too. This one's for Bob maybe. When would you consider a GLP-1 or GLP-1 versus suggesting bariatric surgery?
Well, I think an important message to get across with our patients is ultimately weight loss needs to be maintained. And when it's lifestyle alone, people typically regain their weight. And we know when people stop the incretin mimetics, ultimately they'll regain the weight over a period of months to years. So this is lifelong therapy. Once they start these drugs and get the weight down, get the medical benefits of that, they need to sustain therapy long term. So back to the question, surgery tends to have a more permanent effect. Once the operation is carried out successfully, the weight regain is very modest over time. So those are the kinds of issues you discuss with your patients in terms of making choices going forward.
Great. And then um So go back to Elaine. How can rheumatologists partner with primary care, endocrinology, nutrition, and behavioral health to support weight management and PSA?
Yeah, great question. I think, one of the things that's so interesting about rheumatology is that many of our diseases affect many different organs. So we've been really trained to have to talk to many different specialists because of that multi-system involvement we have with all of our rheumatic diseases. So I think in terms of obesity management, it's the same thing. I think we really need to kind of meet where your environment is. If you have primary cares that are interested in endocrine, nutrition, if you have that network, I would, definitely call ahead and talk to them and see what the patients that they like to see. Cause it's so frustrating for, I think, Alexis and I, when we refer patients to a specialist and they don't want to deal with that, right? Because it's like one step forward and 10 steps back for the patient. So I think it's important that we really do talk to, pick up the phone. I mean, that's what I, do sometimes with my dermatologist, right? When have complex cases with psoriatic arthritis. And I think the same for weight management.
Yeah, totally agree. And having your people lined up so that they know about psoriatic disease. We do that with preventative cardiology and endocrinology. So it's nice to have that relationship so they understand our patient population too.
Mhm.
All right. Well, thank you so much. Um, so thank you so much to both Elaine and Bob. This is a really fun discussion. And it was a lot of fun putting this together because I think we both learned more about the obesity aspects as well. Thank you so much for joining us tonight. Have a
Yeah.
wonderful
Bye,
rest.
bye, everybody. Thanks for being part of this.
Thank you for listening. Remember to download the slides and practice aids and complete the post test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/CKQ860.